Okay. Yeah, I'm going to talk a little bit today about comprehensive integrative pain management, including giving you a definition of what that term's about. But I'm going to start with a little bit of background about why this is such an important issue for us to be paying attention to. So first of all, let me talk about this notion that we have an opioid epidemic. And I think the bad news is that we don't really have an opioid epidemic in this country. Now, for one reason, it's impossible to have an epidemic of a treatment. Opioids are a treatment. You know, the CDC is also concerned about the overuse of antibiotics, but they haven't declared an antibiotic epidemic yet. Epidemics refer to health conditions. The epidemics that we have related to opioids are an epidemic of opioid misuse, an epidemic of opioid overdose, an epidemic of opioid overdose deaths. Those are the epidemics we have. If you listen carefully, you'll see that policymakers now are beginning to adopt that kind of language, particularly the folks at HHS and at FDA, I've noticed, have been using that terminology. But the real reason that this is bad news is that it's not really an opioid epidemic, it's really an opioid syndemic. And a syndemic is even more of a problem than an epidemic. I stumbled across this term actually because it showed up on NPR at the end of January, talking about this new buzzword of syndemic, which is defined as a set of linked health problems involving two or more afflictions interacting synergistically and contributing to an excess burden of disease in a population. We have a syndemic related to opioids. And the three things that are involved in that syndemic are chronic pain, opioid use disorder, and other mental health conditions besides opioid use disorder. All three of those work together to create the problems that we have right now with overdose and misuse of opioids. And they make each other worse in a synergistic manner. They're all huge public health issues in and of themselves. You can see the numbers of people affected with these different problems, the annual costs, and Margaret showed the cost for prescription opioid misuse. The numbers actually go higher if you begin to include illicit opioids and if you begin to include the law enforcement costs as well as the healthcare costs, but they're all dwarfed by what the Institute of Medicine found related to the cost of chronic pain being almost $600 billion a year. Just think if we could solve this problem, we could also solve our budget issue in the United States and in the process get rid of something nobody wanted in the first place. And you know, it'd be kind of an odd thing to do. But the other point is that all three of these problems are associated with significant mortality. We know that for chronic pain, the risk of suicide is 2.5 to 4 times as high as it is among people who don't have chronic pain. We know those with chronic pain who are most at risk of completing suicide are those who also have other mental health conditions. We know that chronic pain causes mental health conditions. We know that some mental health conditions predispose you to developing chronic pain. This stuff all plays together and creates a massive problem for us to deal with. But these problems don't just exist on their own and in isolation. They're also embedded in a system of social determinants that affects these. It's what I call the miasma of misery. We once had a patient who was the type of patient who would sit in the exam room and wait for us to come in, and he'd be filling out the New York Times crossword with ink, you know, just working his way across the lines. And we said to him one day, "How are you doing?" He said, "It's a miasma of misery." And so ever since, it's kind of stuck with me. These problems are embedded in a social situation where we have a society desires an easy solution to our problems. We want the pill that's going to fix all of our problems. We have low educational achievements in some places, and those lead to low economic opportunity, and the despair that's attached to that leads people into substance abuse and leads people to have mental health conditions. We have generational poverty and generational substance use. We have few supports in the community, and I think that maybe even the biggest aspect of all of this is that our degree of social connectedness declines on a daily basis. Our relationships with other people and with institutions in our society is being devastated. You know, we've come to the place where two people will sit next to each other, instead of talking, they'll text, right? You know, that is a real problem for us, and it makes all of these other issues that much worse. In a sense, though, these are really very similar problems. You know, they're all highly prevalent, they're very costly, they're stigmatized. People can be blamed for having all of these problems. And when you're stigmatized, you have no power. in the system. The power of people with chronic pain and with opioid use disorder and with mental health conditions to advocate for their own care is hugely diminished by the stigma that's attached to it. They're all poorly understood by the medical profession. We don't teach this stuff in medical schools. Average content on pain in 4 years of medical school is 9 hours. Average content on substance abuse in 4 years of medical school is 3 hours. And, you know, interestingly enough, there's a study out there looking at veterinary schools that says that the average content on pain in veterinary schools is 90 hours. So I'll let you draw your own conclusions about where you should get your pain care. They're all under-resourced. We don't have the adequate treatment for any of these problems. They're complex problems requiring a biopsychosocial approach, but I think the most important piece is that everyone is suffering. Everyone who has these conditions is suffering in some way, and everyone who loves someone who has one of these conditions is also suffering. And if you start doing the math on that, it's almost all of us who are suffering in some way because of one of these problems. I oftentimes talk about managing pain these days as sort of being like walking a tightrope. You have to be very careful, you have to maintain your balance, and if you fall off of that, all kinds of bad things happen to you and happen to your patients. But even if we get to the end of that tightrope, even if we get to the end of that wire, what do we encounter? We encounter this. It's the Cerberus, the three-headed dog who in Greek mythology is the hound of Hades. And Cerberus's job is to keep people in the underworld. We have these three problems of chronic pain and mental health conditions and opioid use disorder. And if we manage to only deal with one of these two heads, the problem is the other two can still bite us. We have to find a way to grapple with all of this at the same time if we're going to succeed in addressing the opioid problem we have in this country. The solutions that policymakers have offered have been kind of limited. There have been some work in this. And for opioid use disorder, we've seen a lot of work trying to increase access to medication-assisted treatment. We've seen some work related to increased access to naloxone, an opioid antagonist that can be given to someone who's overdosing. And we've seen some increased emphasis on primary prevention. Let's get people to not start opioid abuse or substance abuse, and maybe we'll succeed. With respect to chronic pain, most of the work that's been done is limitations in opioid prescribing and limitations in opioid production. Now, yes, opioids have been overprescribed. There's been a substantial reduction over the past 7 years or so. There's been almost a 30% reduction in the amount of opioids prescribed in this country, and that's probably a good thing. But here's the issue. If we're indiscriminate in what we do with opioids, then we wind up also limiting access to them for people who actually do have a legitimate need for them, and that's a concern. Because let's think about this. If you have a person with chronic pain who's using opioids, rightly or wrongly, to treat that chronic pain, and you take away the opioid, what are you left with? You're left with a person with chronic pain who still needs to have some kind of treatment for that pain. We see encouragement along those lines to use more non-opioid and non-drug treatments. Everybody's encouraging that. The problem is nobody's paying for it. And so we're getting this pressure to use more and more of it, and it's just not reachable for many people. And sadly, I'm not really sure what's been done with respect to mental health over the past few years. I think we need to emphasize that a little bit more and do some more work on that piece as well. These are complex problems that require complex solutions. H.L. Mencken said, for every complex problem, there's a solution that's neat, simple, and wrong. We have three complex problems here, and we have a whole lot of simple solutions out there. Just say no to prescribing opioids is one of those simple solutions. We have to recognize that these are complex biopsychosocial spiritual conditions. Okay? We have to pay attention to the biology of them, the psychology of them, the social aspects, and the spiritual aspects. What do these problems mean for people in their lives? How do they find meaning in their lives? We have to pay attention to all of that if we're going to be successful. Simple treatments such as opioid monotherapy are rarely effective and they're very risky. We need a complex solution. So in the arena of pain care, this is what we think we need. Something is called comprehensive integrative pain care. Now in 2017, we hosted a conference that had representatives from 50 different stakeholder organizations. Those organizations were spread across professional associations, patient advocacy organizations, government agencies, third-party payers, and researchers and policy folks. It was a really great representation of folks, and together we came to this consensus definition. So let me tell you, comprehensive integrative pain management includes biomedical, psychosocial, complementary health, and spiritual care. We need to have all of those kinds of care available for people who have chronic pain. It's person-centered, and it focuses on maximizing function and wellness. It's not about getting your pain rating on a 0 to 10 scale less than 4. If we want to do that, we'll just anesthetize everybody and nobody have any pain. It's about improving your function and wellness, and that can be done even if you don't reduce the pain very much. Care plans are developed through a shared decision-making model that reflects the best available evidence regarding optimal clinical practice and the person's goals and values. Good pain management is not something that happens to a patient. It's something that happens with a patient. We talk about team pain care because it takes a team of people to deliver this kind of care, but the patient and the patient's caregivers are part of that team. And what's wrong with sitting and talking with patients about what they want to accomplish? So we have some barriers to accomplishing this, and we've got limited reimbursement for non-drug and non-device interventions, limited education I've already talked about, referral networks. If a primary care doc wants to find somebody who provides integrative care, how do they find them? We have a limited supply of providers, especially in some geographic areas. I'm from Kansas. There are parts of Kansas where you have to drive 200 miles to find somebody who can even pronounce acupuncture, much less give it to you. We've got some things that we have to get past in order to be able to provide this kind of care to everyone. And so in wrapping up, resolving the opioid syndemic, I think we have to fully recognize how complex this problem is and that it's going to take a complex solution to resolve it. We have to address all three of the problems that are components of this syndemic. We've got to make it possible for healthcare providers to provide comprehensive integrative pain care as part of that solution. And there are a number of legislative and regulatory actions we think can promote expansion of adoption of CIPM. So with that, let me thank you and turn it over to Margaret to introduce our next speaker.